for inviting me at this Congress. Well, actually my speech will, I will do a brief overview of the role of ultrasound in monitoring the respiratory system, so not only the diaphragm, because I consider the diaphragm cannot be separated by the lung conditions and even by the heart conditions. So the first question I should answer is, what am I interested to monitor in mechanically ventilated patient? Well, the first thing that maybe I would like to know is which is the lung illness, which are the lung conditions. Do I have edema? Do I have pneumonia? Do I have pleural effusion? Just 3 short videos for the ones of you that are not used to lung ultrasound. This is a normal lung ultrasound, and what you can see here is, well, you can see the pleural line. I don't know if this works. No, okay. That white hyperechoic line that you can see above, and under the pleural line you can see, well, absolutely nothing, because as the lung is filled of air and the tissue-air interface causes the reflections of 99% of ultrasound, you just see some artifacts and all these gray image. The second pattern, what is called the B pattern, you can start to see these comet tail artifacts or B lines. That is not due to an anatomical structure, but it is due to the presence of the interfaces between some alveoli filled of water and others filled of air. So this is very characteristic of lung edema. And the third pattern is the consolidation that you can find in your patients. There are 2 types of consolidations. On the left one you can see, well, in consolidation you start to see the lung anatomy, the lung structure, because it is collapsed, it has no air inside. But on the left side you can see this consolidation has some white line. The light doesn't work. Some white line and white dots that are that means the presence of air inside the bronchi, so it's more characteristic of a pneumonia, while on the right side you can see no air inside the collapsed lung. You can see the echogenicity is more or less the same of the liver, and with the pleural effusion around. And this is more characteristic of an atelectasis. Anyway, this is the, well, as a fan of ultrasound, this is maybe one of my favorite studies. It is not a large randomized controlled trial, but as I worked in the ICU in Paris with these clinicians of Professor Jean-Jacques Loby, they did this comparison. They compared auscultation, chest radiography, and lung ultrasonography, and this was a kind of dream team of French clinicians, because the auscultations was carried out by Professor Jean-Jacques Loby, the chest radiography was referred to by Dr. Philippe Cluzet, that was one of the best radiology I ever known, and Daniel Lichtenstein performed lung ultrasound, that is maybe the inventor of lung ultrasound. They recruited 32 ARDS patients and examined 384 regions, so 12 regions for each patient, to evaluate, to assess 3 entities: pleural effusion, alveolar consolidation, and alveolar interstitial syndrome, and they compared as a reference method with the CT scan. And, well, sorry. And as you can see here, the diagnostic accuracy was much better for lung ultrasonography than for the other 2 techniques. So the conclusions was that ultrasonography was better than auscultation and bedside chest radiography for diagnosing the three entities: pleural effusion, alveolar consolidation, and interstitial syndrome. This study was, of course, replicated many times and was validated also in pediatric populations. You can see here, this is an example of a pediatric patient, 4 years old, in our pediatric unit. You can see on the left the image of pneumonia, and on the right, because we can, of course, use ultrasound as a follow-up tool, as a tool for follow-up the illness. After 48 hours of antibiotic therapy, you can see the consolidation is largely reduced, and even the small pleural effusion is almost disappears. So the second most studied use of lung ultrasound is maybe the assessment of lung aeration or loss of aeration. So here an example of an ICU ventilated patient in our ICU. You can see on the left the image I show you previously with quite a large pleural effusion and an atelectasis of the right lung. And starting from PEEP of 8, we perform the recruitment maneuver and then set the PEEP higher. And you can see on the right side, 2 minutes after, the same image with the lung that is now more aerated, all these white images that appeared in the lung parenchyma. Well, Balaid Bouhemad tried to give a basis, a systematic basis to this reaeration, trying to find a score to quantify the reaeration. So he defined these 4 conditions of progressive deaeration from normal to B1 that are well-separated B lines, to B2 that are coalescent B lines, and C that are that represents a consolidation. And then he standardized the assessment of the lung diaphragm, of the lung ultrasound, to 6 views for each hemithorax. And as you can see the score here, you have 1 point, you give 1 point of the reaeration passing from one condition to the next one, or 3 points jumping to the third condition, or 5 points from the first to the last. So you can obtain a positive score or a negative score in the sum of these assessments. And the score has been validated, for example, to assess reaeration in ventilator-associated pneumonia, always compared to CT scan, and, for example, assessing the lung aeration loss during a successful winning trial could predict post-extubation distress, for example. Here in this, I show you these data that are not still published. It's just an abstract form where we try to assess reaeration during non-invasive ventilation. I don't know how it works in Russian Federation, but in Italy we have some issues with non-invasive ventilation performed outside the intensive care unit, because we somewhat need to do it, because the number of beds in the ICU is always smaller than we need. But of course there are some concerns, because non-invasive ventilation failure is associated to a higher mortality, mainly because of delayed intubation in a setting that is not intensively monitored. Therefore, we try to see if lung score, lung reaeration score, could predict the non-invasive ventilation success or failure, assessing before starting the non-invasive ventilation and after 60 minutes. And with a few patients, I have to say. For now, this is data with few patients. It seems to have quite a good accuracy. The third thing is, of course, lung edema and the assessment of the extravascular lung water. And it has been, maybe it's the most validated aspect of ultrasound. You can see here a study in which the extravascular lung water has been, the B lines, sorry, has been related to extravascular lung water determined with the Victor system, or as the second study has been compared with lung density measured at CT scan. Talking about the respiratory muscle function workload, I come to talk about the diaphragm ultrasound. The assessment of diaphragmatic dysfunction has been recently studied quite a lot. You can see here we performed a systematic review. These are studied until 2015, that are about 20 studies only in an ICU setting, and they are almost doubled now to 2 years after. And the diaphragmatic ultrasound has been studied mainly in these 4 settings, that is to diagnose the dysfunction or the paralysis of the diaphragm, to predict the weaning success or failure, to assess the respiratory effort in mechanically ventilated patients or in spontaneously breathing patients, and to assess the progression of atrophy, of disease atrophy in our mechanically ventilated patients. The first technique I will show you is the diaphragmatic excursion. It is quite simple, because we have this subcostal view of the diaphragm. You can see the diaphragm is that white line that is adherent to the liver, and in end mode you can have this sort of wave, and measuring the peak with the basis of the wave, we have what is called the diaphragmatic excursion or diaphragmatic inspiratory amplitude. And on the right side you can see the image of a paralyzed diaphragm without excursion, or even with a negative excursion. This is an example. These are cardiac surgery patients that in a spontaneous breathing test were measured with the diaphragm excursion ultrasound, and compared as a reference method with the Gilbert index, that is an index derived by transdiaphragmatic pressure, and they have seen that what they call the best excursion, the maximal excursion the patient could do, less than 25 millimeters, was associated with a severe diaphragmatic dysfunction, that is a Gilbert index lower than 0. Another example here in mechanically ventilated patients during a spontaneous breathing trial. The diaphragmatic dysfunctions was defined as a vertical excursion of less than 10 millimeters or paradoxic movements, and the results were that, well, the diaphragmatic dysfunction was quite frequent. You can see 24 patients out of 88. And it was associated with a higher length of stay, with higher total ventilation time, weaning time, and with primary and secondary weaning failure. But we have to remember that diaphragmatic excursion is related essentially to the tidal volume. And as you can see here in this study by this Italian group of Dr. Umbrello and colleague, when we try to decrease pressure support or increase pressure support in this protocol, you can see the diaphragmatic excursion doesn't change. And this is quite logical, because during pressure support, the excursion is given by the diaphragm workload, but even by the pressure support given by the ventilator. And this also depended by for example, the compliance of the lung. And if we, for example, give a high PEEP the hypoquip with increased lung volumes, it will lower the diaphragmatic dome, and we will have a reduced diaphragmatic excursion, not because of a reduced function, but because the diaphragm will start from a lower position. And of course we have to remember the diaphragmatic excursion can vary with the patient's position or with everything that changes intra-abdominal pressure. But because the diaphragm, we have to remember, is an interface between the thoracic pressure and the intra-abdominal pressure. So with supine position, with obese patients, with every condition that increase intra-abdominal pressure can be reduced. So the second technique that is gaining popularity, I would say, is the assessment of the thickening of the diaphragm. We can measure it at what is called the zone of apposition. So at the base of the lung, you can see in the video, there is the pleural artifact that comes on the right during inspiration, that means downward, and on the left during expiration, and you can identify these two parallel lines that are the pleura and the peritoneum here. And the dark part in between the two is the muscular part, therefore is the diaphragm. And we can measure during inspiration what is called the thickening fraction that you can see here, that is more or less similar to the ejection fraction. That means the difference in the thickening during the inspiratory act divided by the thickness at the end of expiration. Normal values has been reported, more or less they range between 1.5 and 2 millimeters, but they are quite variable between subjects. Thickening fraction seems to be really accurate to assess the workload of diaphragm. In this study performed in non-invasive ventilation after extubation, you can see the protocol with spontaneous breathing patient and increasing level of pressure support. They measure the transdiaphragmatic pressure as a reference method, and you can see as the thickening fraction and transdiaphragmatic pressure decrease in a parallel way as the pressure support increase. That means that the diaphragm is unloaded. We repeated the study in a mechanically ventilated patient, intubated patient, and as you can see, the results are quite similar, passing from spontaneous breathing patient to a controlled mechanical ventilation. The thickening fraction decreased to almost to zero. And in this other study, Dr. Umbrello and colleagues correlated very well the thickening fraction with the esophageal pressure and transdiaphragmatic pressure, again in ventilated patients under pressure support. Goliger and co-workers, Dr. Goliger, in this study correlated also thickening fraction with the electrical activity of diaphragm. This is very interesting, but this is in healthy patients. I expect that in patients with diaphragmatic dysfunctions, we should be in the right low part of the of this image. That means that we, for a given electrical activity, we should lose some contractility, but this has not been studied yet. And as you can see, diaphragmatic thickening is very well correlated with the respiratory workload of the diaphragm. The other important thing we could, I don't want to say we could do with ultrasound, but what in which ultrasound could help us is to have some information during the weaning phase from mechanical ventilation. This is a very recent study still an online version on anesthesiology. When I looked at the title, I was quite enthusiastic because I liked the approach to combine the diaphragm, the cardiac, and the lung ultrasound. But then I'm a little bit critical about that because there are some methodological issues that are being also underlined by Professor Tobin editorial. But what I would like to focus about, they talk about patients who succeed the pressure support ventilation trial, and then they tell us that for diaphragm ultrasonography they recorded changes in diaphragm vertical excursion using an ultrasound, and as we told before, this is not the right technique to assess patients in pressure support ventilator, that they use pressure support as high as 7, so it's not really really low. The results is that the diaphragm ultrasound seem not to be useful at all to predict the distress. And as you can see in this other study, the results are quite opposite because they use thickening fraction and not excursion. And as you can see, even for the patients with the pressure support trial, the test performed quite well. But let me show you, this is not evidence-based. This is what we started to apply in our ICU as a kind of a winning protocol from mechanical ventilation. So we perform a spontaneous breathing trial. Spontaneous breathing, that means a T-tube trial, without pressure support. So we can have a success of the rapid shallow breathing index. Therefore, we still could perform, if I would say, if we had time to do some diaphragm and lung ultrasound, because sometimes we can have some failing extubation, of course, and then we proceed to extubation. But if the spontaneous breathing trial failed, we go back to pressure support ventilation, and then we try to understand what is happening to our patients. So ultrasound should not be used as an index of for weaning for extubation, as an extubation or intubation index. It should be used to understand what is happening. In my opinion, this is, of course, my opinion. This is not evidence-based, as I said. To understand what is happening to my patient who is failing the spontaneous breathing trial. And at this point, with ultrasonography, I could find, for example, a dysfunction of the diaphragm. Then my attitude will be, well, I will wait for recovery. I will try training of muscular, training of respiratory muscle, or maybe I have to choose to go for tracheostomy, or in another possibility is the diaphragm works well, but I can find some B lines on the lungs, so I could have some lung edema. Therefore, I should check for the heart. That is the third possibility. Do I have a cardiac failure, a diastolic dysfunction, or I can find some pleural effusion to you should insert a drain. I could have some de-recruitment, so maybe this could be a group of patients that I could even try to extubate and put under non-invasive ventilation. Well, the last thing I would like to discuss, but I think we are running out of time, so I will not deepen this argument, are the heart-lung interaction. These are especially in our ARDS, mechanically ventilated patients with higher PEEP. I have to remember that the right ventricle often suffers because of the high intrathoracic pressure, and if I do not monitor the right ventricle, the risk is to have this last condition. You can see the video where the severe failure of the right ventricle is happened already, and this is associated with a quite higher mortality. So I would just like to show you this study multicentric study that was performed in many ICU in France, where they found the acute right ventricle failure in the 22% of patients with ARDS. They also did the score that was these patients were more likely to have a pneumonia, to have a higher driving pressure, to have a lower oxygenation and a higher CO2. So summarizing this score, these were the most severe patients probably. And to conclude, I would like to show you that ultrasound can be used to assess lung aeration with a good accuracy, to diagnose and follow up, for example, ventilator-associated pneumonia, pulmonary edema. It can help to in the process of weaning from mechanical ventilation. We know it is easy to use, easy available, it is reliable, non-invasive, cost-effective, it has high sensitivity, specificity, it is fast to obtain. So my question is, okay, so daily, routinely use of ultrasound, of thoracic ultrasound, as we know that lung conditions can change every day and even many times a day, why not? So thank you for the attention.